Hello, hello. Oh, I can't wear my glasses. That's right. Hello, Mark. Kevin. Scott. Allison, hello. Julie, hello. Brian, you're back. We'll give it a few more minutes here. I'm sure more people are coming. And everybody starts on mute, just so you know. So you have to unmute yourself if you're trying to talk to me.
Yeah, there we go.
Hey, Ben, in with audio.
There we go.
It's been a long day, so I'm just like fumbling through the keyboards here.
I understand.
Long week, long month, right?
Hello, Sean.
Good afternoon.
All right, a couple more minutes.
Good afternoon, Ben. Caitlin's on.
Hey, Caitlin. What time do we have? What is it? 2 after? Oh, 1 after. All right. Another minute or so. And yes, for those of you who were not on last week, I am in my closet. So if you see my shoes and my ties that I don't wear anymore, I haven't worn those. It's the quietest place in my house. So just so everyone knows.
And it is very Imelda Marcos of you.
Well, my wife always makes fun of me. She's like, "You have a lot of shoes." I'm like, "I'm not sure." That's like I think there's
I
not
thought you had
there's
an
not
argument or
enough.
something with your wife.
David, welcome. I got a few shoes. I don't know.
Where's the cowboy boots in there? I don't see any boots.
No, Mark, I'm in Detroit, man. There's no cowboy boots. Yeah,
That's where you need them.
probably. Tina, welcome. All right, so we've got Ann. Hold on, people are coming in still. Hold on. Ann, welcome. All right, so we got 15 of us. Actually, a lot of people who weren't here last week, so that's great. Quickly, no like agenda, just rules of the game. Try to like be respectful to everybody. Everyone's going through a rough time. I think this week I was thinking actually to start. I had about every 5 days I have kind of a low moment. Or a low day where you're like, what have I got? What are we doing? So I thought it would be good actually to do a quick, hold on. I got a bunch of people coming in still. Hey, Russell, how you doing?
Hey, I'm good.
Good.
And
We're just getting started.
no worries. I love the shoes. Hope you like my backyard.
It looks better than my shoe rack.
All right.
So I thought it would be good to do just a quick, if you could write in the comments, in the chat, little chat button down there, score your emotional, mental on a scale of 1 to 10, 10 being like, I'm having the best time ever. And 1 being like, I need to check myself in. So like somewhere in between there, like I'm just curious to know where people at, maybe just a quick, and you guys can see what everyone's putting themselves at. All right, good. Yeah, people, this is better than I was expecting. This is good. Some 6s, some 7s.
I meant to use a minus on my number.
You could do that. You could do that. Let's see. We got 3 more here. 6.5. I mean, Julie, a half, really? You gave yourself a half? All right. And a 7, 6. Yeah.
I can't find my number. I'm an 8.5.
Okay, 8.5. Kevin, you're always 8.5, though. I mean, this is it really changed much. So I was just curious to see where people are at. I know I go up and down, so I feel like yesterday was kind of one of those days, right? And I was just kind of overwhelmed by everything, probably. So love to start. I know Michael and Ann were going to talk about metrics, but Michael's not here yet, so maybe we'll wait on that subject. But if anyone wants to start with the current question or issue they're coming up against and want to get feedback, I think it's open floor.
It's David. Hi, everybody.
David,
Kelly.
yeah, tell them where you're from and just your name real quick. That'd be
Sure.
helpful.
Hi, everybody. David Kelly, Director of Physician Rev Cycle for Premier Health Partners in Dayton, Ohio. And Ben, I like the way you started there because this is a bit of a, what do you want to call it, emotional roller coaster right now or whatever the case might be. But I saw a 4 in there, and I wondered if that person needs any help, anything we can do as a group. That's kind of what we're here for, right? So I don't want to pick on whoever that was, but if you need anything, can we do anything for you?
That was
can we help
Scott.
them?
Hey, that's me. I'm Scott from Duke Health. I put a 4 in there, not so much that there are answerable problems and issues that we're all going through, just the acknowledging the inevitable emotional highs and lows that we all go through, and the folks that we support directly and indirectly. On one hand, I'm as stressed with the chaotic environment and the unknown as everyone else. On the other hand, I'm also, recognizing and appreciative of just the sheer amount of things that the collective we across the industry have accomplished. I think all of us at times bemoan our ability to get things done, to get traction on initiatives and priorities that we have. And trying to balance that. But also I look back over the last 30 days, and in most of our organizations, at least in the revenue cycle part of it, we've gone completely virtual, work from home, and some of us were already down that path, some of us not, but shit, it all happened in the last 30 days.
Right.
We can
Right.
bemoan about some of the bureaucracy at the government level, and not meaning to get too political there. But I'm guessing many of us got stimulus checks in our EFTs today or within the next couple of days. Who would have thought that would come together so quickly? It's interesting that we got our stimulus checks a whole lot faster than the general population across the United States. But again, there's a handful of thousands of us, not 200 million checks to be delivered out there. So it is kind of amazing how quickly some things can get done. And to a certain extent, maybe that's a lesson learned for in the future when we're bemoaning how hard it is to get things done. We'll go back and say, think about how when we put our mind to it, things did get done pretty quickly.
Perspective is everything, right?
Yeah.
Perspective is everything. Well, thanks, Scott. I appreciate that. And David for asking. What else? What do other people have that would like to talk about?
I mean, I'll say that I reported a 7 and I might have been a 5, but my number's up because I told my family respectfully that no more board games and no more puzzles. Like, I'm out. It was fun, but I'm out. And so
He's all
now
tapped out.
that's how I got my score up. So there's little things you can do.
No more puzzles, no more board games. We'll keep that for the record. Excellent.
Ben, this is Julie. I think for me, my biggest burning question is, when are we going to get back to normal? And I know the phrase right now is the new normal. I've been having conversations with clients about, elective procedures and when are those going to start back up again. And I have some clients that are saying, well, if census stays the way it is, then there are conversations in the organization that they will start possibly in 2 weeks. So I'd love to hear from you guys on, what's happening in your regions and your facilities, and, what types of conversations are going on to get to that some sort of normalcy again.
Yeah. Well, I mean, in Michigan, at least, there's a stay-at-home order until the end of April. So I think until those are lifted, I don't see elective procedures coming back. But I'd love to hear from other people. I don't know what other states are dealing with.
Ohio.
So we have, I'm sorry, go ahead.
In New York, I would say that, the data for, this week is New York City is showing, a little positivity in that it's flattened. But, we still had 700 deaths yesterday,
Yes.
which is double the normal deaths in the city as big as New York. So I don't see any kind of back to normal and, till sometime in May, mid to late May. And I think normal is going to be very different. And picking up on something that Scott said, I think our organization saw what they can do very fast. And I think that, I think we've all had this feeling that hospitals were a 5-day-a-week operation. And I wouldn't be surprised if we started seeing more activity go on when we get back to normal. whatever, when we get back to getting back to work, and that's really also going to be very phased in. But I think how our entities, whether you're, you know, a hospital or a physician group practice, I think it's going to be really different. You know, we have these huge capital bricks and mortars that barely get used on the weekends that I think people might figure out now we can do it differently.
Yeah, because capacity is going to be the issue, right? You want to get volume back on the surgery, especially the surgery side. You have to build up capacity somehow. Weekend would be the obvious. Sorry, Mark, you were going to say something.
Well, first, for our New York colleagues, we're really sorry to see you know, New York City, the state, just take the toll it's had. Having worked there for about 20 years, you know, it rings true. So sorry for that, and any of other areas that are feeling it. I don't know that we return to normal this year, right? So maybe I'm kind of the gloom and doom, but right, what is going to bring patients back for elective surgery? We're on a remote work order yet for Virginia until, by the way, with University of Virginia, we're remote work order yet until June 10th. That's not changed. After June 10th, and even if we're escape kind of what New York has gone through, I think while there's this discussion of pent up demand, how much demand is there really for electives come rushing back for procedures right that quickly after the coronavirus dies down? And what's the risk of resurgence? And so if we can get back to normal volume, I'd be surprised if we start seeing ourselves coming back to normal volumes in late fall, which means from a revenue cycle standpoint, we're capturing cash back to our current levels in the first quarter calendar year, you know, 2021. That's really sobering. That's, you know, that's a $500 million for us in terms of loss rate. And so if we have that effect and the effect on the economy, we have drastic changes that we need to make in our cost structure. We already did have drastic changes we needed to make. I just see this ushering in a whole new era. So hopefully I didn't bring everyone down to a 1 with that comment.
Well, this is David again.
Change my score.
And I think what's interesting about those perspectives and the question itself is, to me, it's almost like, what do you define first, the path back to normal or normal? Because I don't think, you know, we say new normal, but I think that's actually really meaningful. And I would emphasize everybody to not brush past that, because it's, you know, do we change how our waiting rooms work? Do we change, you know, one of the things I remember early in this coronavirus when they started saying, hey, we're going to screen people going to like the ICU and nursing homes for fevers. And I sort of sat there for a moment dumbstruck and I said, shouldn't we have been doing that for like 100 years? You know, maybe that's a new normal. You know, some of these things that I think we really have to sit down meaningfully, not just RevCycle, but all of our hospital leadership folks, and say, what does normal look like? Because the path to that could be very different to the path to 3 months ago, you know, and could be divergent in some ways. So I think defining that is a really integral part of this conversation. I don't know what it looks like I said, but we got to start talking about it.
One thing I'll offer, I sat in on a talk, and hopefully this is in the positive light, by this CEO of Teladoc, and where their demand curve inverted literally overnight. And in his talk, you know, with providers, they were saying, yeah, we've been sitting around talking about telemedicine taking a long time, and we proved that we can kind of do it, you know, when the pressure's on. So how many of our non-criticals, you know, level 1, level 2 office visits and the like, and certainly scripts and stuff like that, will the whole industry have moved to telemedicine faster, in one of the kind of, you know, silver lining columns? I'd just be curious, is that going on in your organizations?
So
Yes,
I'm
we've
an
lit up
MS.
complete. Sorry.
That's okay. I'm going to say I've been at MSK now. I came from working with Ann at Weill Cornell for a total of 100 days. So I got into a new revenue cycle and had to quickly figure out what I was doing. Yeah. However, MSK really just wasn't using telemedicine in any really strong way, shape, or form. And now they have realized that the technology that they did have isn't really working for them. So we've shifted to FaceTime, all of these other things. We sat on a call yesterday and I kind of laughed to myself because we had to actually say you can't use TikTok. And I don't know who tried to use that at my organization, but apparently it happened. So
That's
you know,
amazing.
there's been, I couldn't believe I was like reading the notes. I'm like, I have to say this. And they're like, yep, please say that you cannot use TikTok. So I don't know where that came up, but
Scott doesn't even know what that is. He's like, is that a watch? What is that?
Something your kids make you do.
Right. But one of the things that, you know, I think just even this week, we've been talking a lot about redeployment of key individuals to areas of need. Since we're in New York, at the beginning of the week, I was told I was going to have to redeploy staff to, you know, cafeterias, environmental services, things like that, and quickly developed a plan. And now we were considered essential workers. So we actually have people being redeployed to us now. From different departments because of the shift in outpatient and things like that. So we're actually planning a huge revenue cycle cleanup. We have about 40 people coming to us. So we're planning to, or at least for me, I'm viewing this as kind of a silver lining for us that we're going to be getting a lot of work done that we normally wouldn't have been. And my team is excited because we're making a lot of changes that would have taken us otherwise a very long time to do. So just a little bit of silver lining in all of this for us.
Laura, I know you're on the phone. You want to weigh in? Maybe. Maybe not. All right, I guess not. Interesting. Anybody else want to weigh in on that? What? So, Allison, you've been working down. Last time we talked about kind of days calculation and what's happening with cash. How's everybody seeing cash now a week later? It sounds like people's Marches were strong, but what's happening in April so far?
Down, down, down.
Yep.
I think for most of us, the cash is totally a function of what the revenue drops are, right? I mean, depending on where you are regionally and geographically, you're seeing that drop in revenue. You know, at Duke, for example, 3 weeks ago, we were at 85% of normal volume. 2 weeks ago at 65%, last week at 50%, this week at about 45 to 50%. So for most of us, 2 to 3 weeks after that drop is when the cash, you know, follows to a certain extent. And, you know, the unknown is how far that continues, but there's no, I look at it and say, most of the things that we stress out about in revenue cycle performance, our denial rate, our avoidable write-off rate, our AR aging, that is really, all of that is virtually dwarfed by what's going on with revenue changes. So we can worry about that, but the solution is not that we get our denial rate down by another percentage or two. The solution is we've got to figure out how to get the clinical volume back up to normal, and everything else is a rounding error.
So what are CFOs asking from everybody? Like, what do they want to know? Like, are CFOs freaking out? They want to predict the cash. Like, how is that? What is happening with that? I guess is probably a good question that I have. I imagine the CFOs are freaking out a little bit around just to predicting it. They're already freaking out, but like predicting what it would look like.
That's what I'm working on. Yeah.
Sean, what did you say?
I'm in my data cave all day long looking at predicted cash. That's what is on top of mind. And trying to measure that elective procedure revenue, and if things do get somewhat back to, can we turn some procedures on, which ones do we turn on and when? Those are the questions they're asking.
So about the only place we've not had an outpatient volume drop is our, chemotherapy services, our oncology units, right? That's still going, our stem cells, those type of urgent needs. Our census almost for the entire month of March was in the low 60s. It dropped really quickly. It stabilized at about 60%. Our ambulatory volume, it's gone completely. We've removed all electives, and that's just hit the basement. So to Scott's point, right, the big issue is that for March, $100 million deficit in terms of gross revenue. That's about 25 million. April, I think it's another, 250, 300, 400 million, 200 million reduction. And then we're going to just start seeing April start to cave. It's not caved yet for us in terms of cash collections because of some of the, we have a 41-day AR. So, there's still some AR cycling, there's still some aging cycling in for all of us, but I think April will be, if we're fortunate, it'll be a 30% reduction on March. If it goes where I think it could go, 50% of our cash flow is gone from the AR already by April.
Welcome, Michael. You're just in time.
Hi, everybody. Why are you ending?
We were waiting for your great analysis. We were hoping you'd have like the answer.
So which one?
Predicting cash.
Oh, I can show you what we've done. Let me try to get it onto my computer. Sure. Hi, everybody.
Does everybody know Michael? Why don't you just do a quick intro, Michael?
Sure. Hi, I'm Michael Mercurio. Nice to speak with all of you. I work at the Partners in Boston, and I'm oversee all the Partners PB world. So I'm just go off for a second. I'll be right back. Okay.
Yeah, no worries. No
Thanks.
pressure. I mean, we're just waiting. It's no big deal.
I'm curious from the group, what if anything, most of us are still working through the initial round of being shell-shocked with all the changes there, but for the group on the call, have your organizations started to get into belt tightening mode at this point? I mean, getting back to what Ben was saying, from a CFO perspective, we're trying to figure out how we absorb the margin losses and however long that plays out. We're all in different, environment in terms of how much we have or don't have in reserves. There's some Medicare accelerated money that will come up, but that's just delaying the inevitable pain that we're going to feel. There's some stimulus money that's going to help out there. But at the burn rates most of our large organizations are going through, at some point, someone's going to have to start making some harder decisions about what are you looking at with furloughs and layoffs and reduction in benefits or no raises or things like that. Has that started to percolate up at any of your organizations yet?
Yeah, so we have. I don't know how much I'm at liberty to get into out in the world of the public, but we definitely have a focus on trying to the normal that operations does, the staffing to volume. Just the phrase I always like to do with these types of things is turned up to 11, right? It's what does our volumes look like? What does that hit within the revenue cycle, within business support, corporate shared services? But yeah, it's definitely something that's underway for us with Premier. And I know that it was announced, I think Mercy down the road in Cincinnati, Mercy Bon Secours, I think they've announced a bunch of furloughing, I think 700 employees. So, I mean, it's certainly in Ohio that there's a couple of the health systems that's touching on. And I think I've read it elsewhere as well. So.
Others?
Hey everyone, Russell Siebert here with VisIQuate. Good to be chatting with everyone. I'm curious, back on the cash discussion, if you all as leaders in your organizations are now like going laser focus into your over 60 AR and other areas, looking for opportunities that may have been missed previously, and if that's yielding any results.
I think all of us are probably doing that. I think part of the challenge there is even if the opportunities are there, the payers are struggling through the same challenges that we are, from staffing and remote and what they're using for offshore and the rest of that. So I hate to say it's wishful thinking on our part, but I think we're going to be, this great opportunity to a certain extent of the next 30, 60, 90 days for us to dig into that is maybe a little bit challenging in terms of that. That's just been our experience so far, that it's not that payers are not wanting to participate and contribute, that they're the other side of us in terms of having the same challenges. That's what we've seen.
Yeah, agreed. Scott, we're trying to do that. We're trying to get as much cash in as quickly as we can. We did receive some of the stimulus money today, which was great. I'm sure a lot of you did as well, or yesterday, but it's on its way for sure. So that'll help, but it's not gonna solve the problem in the long term. We're starting to have the conversations around when do we have to think about something more drastic around reduction in hours or something, but we haven't gotten to been mandated to implement anything yet.
Yeah, I do expect the AR to be flogged like it's never been flogged before, but we've done some things with some vendors where we've used outsourced vendors for low-level denials or clinical appeals. We're looking at shifting some of our team into that space just to ensure we can reduce some of that contingency fee that was needed before, but now we'll have some excess capacity. And so we're doing things like that, but those are really, compared to the cash flow hit we're all taking, that's just an incremental touch. It helps, but nowhere near meets the needs. So our needs are about 4 million a day, which might be dwarfed by a number of your organizations, but it's still considerable output. And if we cut that revenue in half to support that, right? So those items that you talked about, potentially, pay reductions, furloughing, they're in discussion. They're not been announced. They're in discussion, right? The organization said they really want to stand by the employees. It's a remarkable thing, but it's really a timing issue of how long they can make that commitment.
Yeah.
We've captured, I stopped hiring new employees or vacancies a month ago with the situation arising. We just froze all approved vacancies, even if they're in the middle of hiring, just as a start, because we know it's going to get tighter. So we just basically said, let's freeze it ourselves because the orders are going to be coming from on high anyway. So, and those are small incremental efforts. We've had requests to start redeployment. That's been a wake-up call for team members on the back side of the aisle that have not worked access roles. And so a bit of a shock, and the number of exemption requests that I saw in that request were staggering. 60% of our staff requested exemptions to go and do patient screening, right? And so and some of them are really heartbreaking things that you see, but it's really been a wake-up call for a lot of our back office staff to recognize that we are a healthcare facility. Our mission is patients. So just kind of a personal situation for many of our team members coming into that realization that can be redeployed, and it shocks them.
Yeah, we're in the redeployment as well, and we're seeing similar challenge with people not wanting to go do that. So, although we have some doctors who've never done inpatient rounding now covering ICUs. So
there you go.
Yep.
Here's your orientation.
Yeah,
exactly.
And speaking of that, I think that what's been really interesting to see is, your contracted folks, your providers, it can be, obviously, if you want to, as an organization, do anything there with their comp, with their float, with their whatever, that can be challenging. You can put yourself into legal risks around the contract. And I've been just really impressed around my organization. The providers are volunteering. Hey, I'll float to that if we need to. We haven't yet, but if we need to, I'll float to that ICU. I'll reduce my compensation voluntarily for 8 weeks, for 3 months, for whatever. So our providers are really stepping up to the plate as well, which is really, it helps up that score from the beginning of the call for me, just to see that this is all hands on deck, everybody on board, stepping up to the plate. So for me, that's been really, really cool to see that they want to take part in contributing as well.
All right, Michael, you ready with your model?
Yeah.
There we go.
Let's see if this is. Can you see my screen?
I can see a great picture of the water.
Can you see that?
There.
No.
Oh, all right. Why is that not working? Huh. I'll keep trying. Sorry. We have some time. You can see the
I
picture
think
of the water. That's not
that
helpful.
picture is my
It's
CFO's
technology.
cash flow
It's
model
technology.
Why is it? Yeah.
underwater.
Hold on.
He's like, the model is you go out in the water and you don't come back. That's the
That's a-
model.
Good luck.
So good
Thanks for
luck.
coming in.
It's
I'll
like
figure
that
this
guy.
out.
Who's the billionaire guy who sent the picture as like social distancing and he took a picture of his like 600-foot yacht?
Oh yeah, David Geffen.
David Geffen. That guy.
That's one of the COVID Darwin Awards of the year. For sure.
Kind of just didn't get it, did he? Mm-hmm.
Not too smart.
So I'm not sure why it's not showing up.
Are you trying to show an Excel file or?
I put it on the desktop.
I think it shows where he is. He's having happy hour right now, looking at that
Yeah,
scene. I think is what's
he's at-
happening.
No, it's not working.
Zoom usually makes you pick the screen that you want to view.
Correct.
Yeah,
It says all it said is let's see.
It usually gives you like whatever is up on your desktop, and you have to pick it.
It won't let me do that. I see nothing.
Oh.
I see nothing.
Do you want to send it to me? Is it a file? What is it?
Yeah, I can try that. Hold on.
Like hieroglyphics? Is it like you just
Ben,
writing?
is this a black market version of Zoom you got us on?
Yeah, what's going on with this, Ben?
Is there such a thing? Because
I
I'd
keep
like
waiting
to.
for someone to bomb in, Zoom bomb in from somewhere, right?
Yeah, Ben,
Oh.
I'll send it to you. Hold on a sec.
I'm trying to prevent that as much as I can. At first, when I did this, I put it out, like an open Zoom, and then they changed it, and it was like they made a waiting room, and then I was like, I should make people register at least. Like, I don't want somebody just showing up.
Hearing all our darkest days.
All right, Ben, I just sent it to you.
Okay, all right, talk amongst yourselves for a minute here.
I was going
I
to
have a
share
quick question.
one of the
Go ahead,
things I
Scott.
heard. One of the things I heard from my organization today is we've been, as many places have been, struggling with maintaining nursing populations, nursing employees in the last several years. So we're about 30% travelers in our inpatient hospital. And the word that came out today was that a number of our traveling nurses are basically leaving us to head up to the Northeast because the premiums are so much higher of what they're willing to pay because of business needs up there. Kind of hard to argue with to a certain extent, but the dislocation and the relocation that's occurring is across the country.
Well, I did hear that New York Presbyterian today, we got some nurses, physician, respiratory therapists coming from upstate New York. Cornell University's in Ithaca, and the medical center there, Cuyahoga is sending. But I also heard we're getting people either today or early Monday from UCSF, and then also from Cleveland Clinic. So I haven't heard any from your traveling nurses, Scott.
Oh, look at that. Wow, that looks great, Ben.
Magic.
Yeah. So what we tried to do is we just took an average daily revenue and we looked through March 15th, which is the blue line, and we held that constant for the fiscal year. Ours starts 10/1 through March 15th. And we figured what the average daily revenue was across all calendar days. And then we basically looked at what the rolling 14-day was on each of the dates on the left-hand column and then graphed that. So you can see that this particular hospital or physicians organization rather has had their ADR going down pretty significantly. In the graph, we project then based on the ADR on March 16th, in the table, we figure out what's the ADR as of that date and how many days are left in the month to figure out what the projected charges would be for the rest of the month. And then we show what they would be, show what they are from a projection perspective. And then we compare that to the baseline. On the right-hand side, we then look to the next couple of months based on whatever day we are and say, okay, on the 16th of March, what's the ADR? And there are 30 days in April, multiply that times 30, and then you get this information. At the very bottom right, we then project out, or in the bottom below the gray line, we project out payments. And what we did is we just took the budgeted collection rate for that particular entity's whatever month it is, figuring that's the best way to try to identify what the cash would be. We recognize our payer and our service mix is going to change, but right now the best estimate until we have some data is what the budgeted collection rate is. So it's obviously pretty rosy. And then you can see where your projected payments are every day compared to what the budget was and then what the gap is. And then this changes on a daily basis. And the nice thing is it projects out the rest of this month plus the next 3. So you can see that this hospital is going to be down, $12 million basically as of between the March through June. It's one data point. It's one, they're doing their own analysis, but from the billing perspective, we kind of gave them a what's the patient cash perspective. It obviously doesn't tie to their total cash outlay because they're stopping spending on FTEs and capital and such. It also shows you where if you're getting to how deep the U is, it's obviously not going to be a V rebound. We're going to be in some sort of a U. So we can start to say, okay, we're at the bottom, which is great. We know we're there and we can plan accordingly.
Michael, how did you do I'm sorry, I might have missed it, the total projected charges? How are you estimating that? Just a straight percentage down?
Yeah, so on March 16th, we have the actual month to date, which is through the 15th. And then we knew that the average daily charges as of the 16th for the 14 rolling days was $495. So we multiplied $495 times the rest of month charges, however many days are left in that month. And then we added those two of actual plus the ROM to get to the total projected. So every day it changes based on what the 14-day rolling is, based on how many more days are in the month.
I mean, in theory, you're getting, I understand but you're not trying to predict cash at this point.
We are at the bottom. This is just, you're right. This is just revenue. The net revenue is on the bottom, Ben. And what we did is we took the collection rate of the budgeted for that month. And whatever the most recent day is, we project out the payments based on what the rest of month total charges are. So you have an idea of where you might be.
I see what you're saying.
March isn't a great way to project cash because we were ahead of budget in cash for March. And so this model doesn't work during the transition period as well as it might work further away from when the world went sideways.
Hey, Michael, for
Yep.
you all and for the group as a whole, as we're trying to translate what charges and revenue are into cash,
Yeah.
Assuming that historical collection rate is probably, I think we'd all agree, is somewhat optimistic. Hopefully, we're going to see payers continue to pay in a timely manner, but for the portion of the collections related to patient responsibility, that is also going to drop like a bucket, drop significantly, partly because volume's down, but partly because patients are just hoarding cash and not willing to pay bills. I was curious to see what experience so far, realizing we're on the front end of it so far, folks have seen in terms of patient payments or willingness to pay drop off. Are people seeing that significantly or hard to tell?
Absolutely. We are. I'm going to pull up a number and then I'll share it in a second. Somebody sent me something.
I know for Memorial Sloan Kettering, we just talked about it. We had an increase of charity care applications by 40% over the last 2 weeks.
Yeah, exactly.
And for us through March end, we were actually pretty flat on that. So at least in the non-bad debt realm, the bad debt, I think, is where we're seeing that. But whatever, everybody's got a different name for it. But the good AR, that's patient balance, we're not seeing that yet. It's pretty flat.
So Scott, our 4-week rolling average for self-pay cash was 7.5 million. Last week it was 9.1 million. And through yesterday, it's 3.4 million. So we're down 50% on the 4-week average, basically, and with just 1 day to go in the week, and we're not going to get $8 million today. Our normal Friday is about 700,000.
So that's pretty consistent with what we've seen. And again, you guys are a little bit ahead of the curve up in the Northeast than where we are in North Carolina. But for the most recent week, because we're tracking this weekly, we've seen patient cash dry up by about 50%. Now, some of that 50% is a reduction of outpatient volume and the copays that you collect from that. But a fair amount of it is patients, just, people that were on payment plans, asking for extensions or not paying. And understandably, I mean, they're either unemployed, which means we're all getting higher amounts of financial assistance applications. But even for the folks that, are still employed, they're worried about the future. And while from an employment perspective, healthcare is an essential employment, that's why everybody's still working in our operations. From an expense perspective, I'm not sure paying your healthcare bill is quite as essential as paying rent and food and everything else.
It's never been.
Yeah. Hey, Ben, I have something too. If you want, if you want something else to see, Michael, it's kind of close to you, your results.
Yeah.
Let me, I have a.
Let's see if you can share it though.
Yeah,
I'm gonna the real test if it's user error or it's like actually Zoom.
Totally a picnic problem.
Just
so
a question.
And this is a few years. This is a few days old, but this is my. Did I share that?
Yep.
I mean, it looks fancier, but
it's definitely fancy. Yeah, yeah.
Let's see if it's better.
So this is my sample data set. It's a few years. I wish a few days old, but same thing. It's the 30-day. This is a true cash prediction, but it is based off gross revenue, and this was as of Monday. So these charges, this is gross revenue through Monday. We go out for 7 days and try to estimate future gross revenue just for 7 days. We don't want to get too crazy, and then we estimate payments, cash on those charges, and these payments are estimated off of historical performance, which is a problem since 2019 is much different than middle of March of 2020. So this is based off of down to the detail of which payer was charged and which patient type. So there's like 1,100 combinations of these things, and we can kind of tell, well, if this gross revenue came in for this particular payer or this particular detailed patient type, we can kind of figure out that cash is going to come in at 19% and come in 42 days later on average. So that's how we just kind of grow that out. And I've got a couple of different models going, and it just keeps going down though. No matter which model I try, it's like holy. And every day it updates, the 30-day model out just goes lower and lower and lower. It's crazy.
Sean, you could just multiply it by 2. It'll look great.
Yeah, I mean, what's the issue? Can't you work your magic?
You don't see a troughing yet on your model yet, though, right?
Not yet.
Uh-oh.
Is this John Muir data or just sample data?
It's sample data, but it is based off of reality of, yes, John Muir.
Okay.
But yeah, it's the same trend.
What you need is some of that new IHME data that suddenly brings all the COVID models lower. You need like the inverse of that here that suddenly brings the cash higher.
I know. I do want to throw in some stimulus money in here too somehow.
That'd
be great. Outpatient looks even worse if you just look at outpatient, so that which makes sense.
Wow.
How is the stimulus money coming to you guys? Just one like lump sum, or is it coming in like?
That's what we got.
We had a lump sum. And it didn't tie to anything that we really could tie back to.
I mean, CMS, rather, as best I can tell, rather than making everybody apply, they just took a look at all the hospitals and physicians and took a look at their collections last year and said, we're going to give you a prorated share of $30 billion. So I think they did the initial $30 billion out of the $100 billion and sent it to everybody roughly today.
Have you looked at the notice that comes with the lump sum? I saw that today. I can pull it up. I won't share it. I'll read it. It's only one sentence. Is that, anyone seen that? It's a bit of a concern just in terms of how to manage the patient component.
Yeah.
The attestation piece?
Yeah, the attestation that you're, find the exact language. Does someone know what I'm referring to? If you have it faster, go ahead.
I don't have it
Go through.
faster, but I've heard of what you're talking about. There's some handcuffs implied in there.
Yes, there are. Have you,
I mean, the handcuffs are basically that we're promising that we won't bill patients for any COVID services, right?
that are higher than an the out-of-network patients especially is kind of the language that I read in that.
But I was going to, in a similar fashion, I was going to ask the group that gradually it appears that most of the payers are coming out with policies that say for COVID-related services, not just the initial testing, but any downstream services, that they will adjudicate claims without any patient responsibility. And so I'm assuming that peer pressure and or government pressure is going to force all the payers in that direction. But for everybody around the table, are we generally heading in the direction? I mean, I think we are at Duke, basically saying, regardless of how payers adjudicate COVID-related claims, that downstream from that, any patient responsibility for insured patients and the entire balance for uninsured patients, that we would not go after patients for COVID activity.
So we've
not doing that.
Go ahead, Mark.
Yeah. So, Scott, if I can, I'll read the language and I'll get back to, if I can, I'll answer it or answer in turn. So here's the notice. Accordingly, for all care for a possible or actual case of COVID-19, recipient certifies that will not seek to collect from the patient out-of-pocket expenses in amount greater than what the patient would have otherwise been required to pay if the care has been provided by an in-network recipient. So that's the quick little note they had on that. Money with attachments, right? So we've made a decision on COVID care that we want because AHIM has produced a good document of what payers are doing, but we're billing everything and wanting the payers to adjudicate it and then balance bill to what they've said to allow the carrier to be part of the mitigation of that out of pocket with the patient. Otherwise, we were afraid that we get into a line, right? How long will COVID forgiveness last? And so, right, wrong, or indifferent, we took the approach of let's adjudicate, let's balance bill, and let's let the payer work with us and the patient by letting the patient see the EOB. We balance bill appropriately, and then we work together to resolve it. But then we're allowing the government and the payer to put an end date. So, for example, Aetna said, I think for cases through June 1 that were COVID, they're forgiving and waiving the coinsurance. On self-pay, we said, well, much like the state and feds that said there's no out-of-pocket related to a test, we're writing off the test for all uninsured patients, period. And we're working to get reimbursed with that through a different mechanism. We've not stipulated for how long, but we've taken that approach, with the COVID test. With clinic visits related to COVID, which could be a cold, we're still billing as we normally did, applying financial and charity assistance and things of that nature. So with our waiver, that we're going to change as the government regulatory guidance changes around this space. So we've taken that approach because we were concerned about some other things we've done in the past where there's no end to the forgiveness line, right? We're writing things off from 3 years ago for certain events we went through.
Now, can I go back real quick to Scott? You were saying the payer is going to adjudicate it without a balance. Let me just take an example. Let's just say I have a high deductible plan. I've got a $7,000 deductible. And I go in and I have a COVID related, I'm in the hospital for a long time. Are you saying that they're still going to pay you minus the $7,000 that the patient would owe you? And then they're saying don't write the patient, so they're going to write you a check for the rest? Or how is that? Is the insurance going to pay you the $7,000?
They're going to process the claim and pay at their allowed amount, and not incorporate any patient responsibility.
As if the patient responsibility didn't exist.
Right.
Okay, I see.
That's my impression of where most of the payers, at least in our market, have either gotten to or appear to be going to as peer pressure and government pressure to them.
Right.
I would agree, and we've seen that, but we've also seen date stipulations of how long they'll honor it. right? And so that's kind of the concerning point about not balanced billing. Well, what happens if that payer says, well, you know, our agreement is good through June, and now we've got cases are repeating, respiratory issues related to COVID coming back a year later. How do we treat that, for example?
It's a great point because while you know we're all working through the first round or two of surges, COVID's not going to disappear come June or July. We're probably a good year of multiple minor surges activity going through, and nobody has that crystal ball.
Well, and the traditional, you know, after service 6 months later insurance discovery, right, where you thought they had Anthem and actually they got Aetna, you know, or whatever the case might be, and you got to go back and now you're outside of that window. So that's a very good point. For myself, you know, my wheelhouse is the professional side. So our focus, my life's been all telehealth all the time for what, 3.5 weeks now. And so what we're doing is we're working to try to cap patient responsibility on telehealth, not just COVID, but in general, because the payer rules seem to be changing a couple times a week, and staying on top of that and who's covered for what and whatever. We just want to help our patients not have to worry about that and be able to see their provider, particularly if they've got a chronic condition. So we're capping that in my wheelhouse. I know my facility partners at Premier are probably talking about the COVID, but the rest of it we're really handling, like Mark said, and kind of doing our normal process. One of the things I was really looking forward to this call this afternoon, though, is I want to make sure you're all thinking about, and if you've got managed care responsibilities, it's you, and if not, you may want to reach out to your managed care groups. So if you've got any sort of freestanding testing site, a drive-through testing site, anything like that where you're doing the labs or responsibility for those labs, the definition of COVID related, right? Because the CDC or the FDA guidelines require a PCR first that reflexes to the COVID test so that we're not wasting COVID tests. And at least in Ohio, that maybe that's an ODH, Ohio Department of Health guidance, but I thought it was a CDC guidance. And so what we've seen right now, and I don't think it's any fault of the payers, they're all swarming as fast as us, right, to try to figure out this universe. That PCR has local coverage determinations. It has restrictions on that. It may not have that waiver of patient liability if it's not defined as COVID related. So I would encourage you to reach out to your managed care departments, to the payers, to say, are you going to consider that to be COVID related? Because if it's a CDC guideline, we literally can't do the COVID test without doing the PCR first. So we learned that midweek this week, and that's definitely something we're working on. Again, I think the payers just didn't think about it. I know I didn't until it came up. So something I want to put out to all my peers here and encourage you guys to think about.
Something else to consider as you kind of go through these payer analysis is the unemployment rate, and in the future, how many patients will become uninsured due to the unemployment.
That's a great point.
Also, on the professional fee side, I saw Medicare put something out saying that they're going to waive deductible and copays for COVID-related with a CS modifier. So I don't know if that's something you're aware of or saw effective March 18th and thereafter.
Yeah, that was another recent. I think they published that, but made it retroactive. So,
yeah, they published that 2-3 days.
Yeah.
And the reason I bring it up is you were talking about what's the standard for COVID related. So maybe there's something in those definitions from CMS that will help you with the payers.
That's a good idea. Thank you.
You're welcome.
All right. Anything else from anybody? Got just a couple of minutes left.
I have a quick question. Are any of you advising your agencies to temper down, reduce credit bureau reporting? We've taken a number of actions. Of course, we were in some major headlines earlier this year, if you didn't notice. But we've really, asked, they're going to suspend credit bureau reporting, for example. They're really toning back. We're actually going to suspend bad debt write-offs for some period of time due to the unemployment issue that's just been mentioned. So we're taking a number of actions like that. I'm curious about the rest of you.
This is Kalen with Capia. We've decided on funding that we do in the next 3 months that while we will fund the provider, we are not taking any kind of collection actions until July 1st, minimally, to kind of evaluate how the employment environment goes. So we have kind of self-throttled to prevent any ill will.
Mark, we did the same thing as you. So a couple of weeks ago, we stopped doing any new bad debt placements and told the agencies to stand down on any active collections on existing placements. The only thing they're doing is what we call passive collections on payment plans that they had already set up. So they're still accepting any money that the patients are sending, but stopped anything aggressive going forward.
I'm assuming that's what pretty much everyone's done by the nods. Excellent. All right. Well, every Friday for the ongoing in our new normal at 4. So Eastern, I know some of you, it's like mid-afternoon, but I don't know if you got, again, think of questions that you can bring to the group or things that like Michael brought so nicely and Sean. I'm sure they'd be happy to send out something, their little formula. So yeah, and again, pass it off to other provider, other people in RevCycle that you think would be, think would benefit from it. I think it's been great. I also, I'd highly recommend everybody, if you've never listened to Brene Brown's podcast, she did an episode on comparative suffering, and I thought it was fantastic. Check it out. Could be a little lift you up from a 4 to a 5 maybe. But we'll try to check in every week and just see how people are doing. And it's okay to be a 2 or a 3, just so everyone understands. It's okay to have a day or 2 or whatever it is. So hope it's been helpful. Everyone stay safe and message me if you need any help, I guess.
Thanks, Ben.
Thanks, Ben,
Thank
for
you,
putting us
everybody.
together.
Easter, everybody.
Everybody.
Happy
Bye-bye.
Easter. Bye-bye.
Happy Passover and Easter.
Take care. Bye.